That brings up the whole issue of Dex. We've talked about that, but where are you using it particularly after day 1? I think we're all comfortable, even with immunotherapy patients, low dose on day 1. But for HEC regimens, if you're giving CIS, for example, it's still in there to give for multiple days. So what's your approach to that? Eric, how are you using Dex these days?
So after cycle 1 or even cycle 2, if patients are tolerating it well, the chemotherapy or the immunotherapy well, that's the first drug that I'm going to cut back, is especially on days 2 through 4. So insomnia is a major concern, and so for those patients with insomnia, that's usually the one I'm going to cut back first.
Yeah, we're still doing the traditional, Dex for 2 to 4 days afterwards. I think logistically, though, it's, even though a lot of these are built into the EMRs and prescriptions, I think it's still not necessarily on everybody's radar to prescribe the delayed Dex, even though it's there and it's available. So I think that's still kind of where we're missing the boat. But it's nice, too, now that we're at least getting some newer data to say that maybe we can use more Dex-sparing approaches and not decrease the overall efficacy of the regimen.
Yeah, at least in the AC setting, there's a good evidence now in the randomized trial setting that AC treated with palonosetron and 1 day of Dex and an NK1 will be effective, and you don't need the extra Dex in those patients. When you, particularly with AC given in a dose-dense regimen where it's 14 days, you're giving Dex for 4 out of 4. It's a lot of Dex, and patients are diabetic, it exacerbates that, or even pre-diabetic. We see a lot of that in our patients.
Yeah, we're typically following the guidelines, so we'll give them for HEC regimens at least 2 extra days after day 1, but would love to cut it back, and we hand it out to the patient. So they have the dexamethasone in their hands, so we're not worried about that, and they typically take it. So until we see something which says, yeah, we can back off, we're going to continue.
And so do you use response in previous cycles to make that decision, as Eric said, or you pretty much straight go straight through?
If it works,
If it works,
we're not, we're not, fixing something that's not broken.
Okay, good.
I can definitely tell you, in our immunotherapy plus chemo regimens, I'm not going to give the 4 days afterwards or 3 days afterwards. That I won't do. I think in the highly emetogenics, we tend to do it. I can also say with dexamethasone that if I have a patient who's having significant nausea, vomiting into days 5, 6, and 7, I will extend the Dex, even at just a slower taper off and step down off for them. And I think that's actually helpful in that setting, even though sniffing diabetes even, I would probably keep it away, even if they're slightly diabetic.
Dex is a double-edged sword. So, I have a senior adult population, so they sometimes can be a little bit more sensitive, and then we have the diabetes component. But I always feel like if we try to do right by the patient and give them enough Dex for like 2 cycles, you always get bit on that, because if they have it in their hands, they take all of it. So then you've got these patients that took days worth of Dex, and then you run into trouble with the duration and all that kind of thing. So it's sometimes a little bit tough to manipulate.
This discussion highlights that even after 30 years of experience, there's still a lot of things that we don't know, and it's feel and expertise, which of course is true for medicine.